Today I'm going to talk about anatomy of the lower extremity, and I'm going to try to go all the way through femur. I'm going to leave it on this view so I can move the images around a little bit, but there are some similarities and yet some differences between the hands and feet as far as the anatomical structure and the counting of the individual bones. So the foot is really wedge shaped. It's a pretty steep wedge, so there's a considerable difference between the toes and the proximal portion of the foot. We'll talk about the imaging things that you need to know about that in the positioning portion, and I'll touch on it a little bit here as well. So the bones consist of 26 bones divided into three parts. So you got your tarsal bones, which are kind of sort of like your carpal bones in your wrist, and then you have the bones that make up the arch of the foot, and those will be your tarsal bones. I have a tendency to speak before I really think sometimes, and once in a while I'll call the tarsal bones carpal bones. Sometimes I'll call the carpal bones tarsal bones. So just understand that if I trip up and I say the carpal bones, that what I'm talking about are the tarsal bones. And then you have the phalanges as well. So just like in the hands, you've got three sets of bones between the hand and the wrist. In the hand, you've got carpals, metacarpals, and phalanges. And in the foot, you have tarsals, metatarsals, and phalanges. So you have 14 phalanges. You have two in the great toe, just like you have two in the thumb. You've got two in the great toe, and then you've got three in the rest of them. And they likewise are going to be named by position. The interphalangeal joints, I'm not going to go very deeply into that because we talked about that in the upper extremity. So I'm not going to go through it in the lower extremity, but they follow the same pattern with proximal and distal interphalangeal joints and so forth. But the numbering is exactly backwards from what it was in the upper extremity. So where we had in our upper extremity anatomical position, our thumb being lateral most finger, we counted from the outside in. We went 1, 2, 3, 4, 5. In the toes, it kind of follows the same pattern, but yet at the same time, it's exactly backwards. The great toe being on the inside, the big toe, kind of like your thumb, that's going to be your number one. So they're going to count from medial to lateral. 1, 2, 3, 4, 5 in the toes. But aside from that, the numbering and the identification of the interphalangeal joints or the metatarsal phalangeal joints, either one follow the same pattern. Also, imaging of the individual toes, if you find yourself in position where you're having to take images of individual toes, then the placement of the foot on one side versus the other is going to follow the same pattern as well. You always want to minimize the OID, so your first or second toe would be with the medial side down, and the rest would be with your lateral side down. In my personal experience, whenever we do toes, we do all toes. So you're going to have some superimposition. If you want to separate the one broken toe from the rest, then you're going to have to do something to make that happen. Toes, unlike fingers, you can't really move an individual toe by itself. If you can, then I would really like to see that. I've never met anybody who could. So you have 5 metatarsals, and they also count from outside in. And just like in the metatarsals, metacarpals, there we go, you have a base and a head, and the base is at the proximal end, and the head's at the distal end. So the distal end articulates with the phalanges. And then your tarsal bones are going to be your calcaneus, which is your heel bone. That's all the way on the bottom. Directly above that, you have your talus, and you've got a navicular here. You've got a cuboid, and that is going to be over here, right there on the proximal lateral most side. And then you've got 3 cuneiform. So you have a lateral cuneiform, an intermediate cuneiform, and a medial cuneiform. We're not going to talk about the individual facets and things like that on the calcaneus or any of the other tarsal bones, That's what it looks like, but the calcaneus, in my experience, is the most commonly fractured of the tarsal bones. If somebody falls from a height, they land hard enough on their heel, they will fracture their heel. Uh, if you view the um, the lower extremity, the very first lower extremity video, there are some pictures in there of X-rays, and I added some to this slideshow after that was recorded. So I'll give you a look at what a broken calcaneus looks like. And they can be pretty nasty and very painful. Probably the second most common I've seen, and I've only seen it once or twice, and that is a broken talus. And that occurs in high impact collisions and things like that as well. So car wrecks, possibly airplane wrecks. And so, as a result, in a lot of cases, a broken talus is going to be referred to as an aviator's fracture for that reason. You brace yourself for impact and you break the bones in your foot. We're not going to talk any more about the individual bones in the feet. There is a mnemonic for that. I've never heard anybody use this, and I've not seen just a lot of reference to individual tarsal bones, with the exception of the calcaneus and the talus, with the exception of the cuboid. So again, if you view the first lower extremity video that I recorded yesterday, you'll see on the oblique, what you can see is the joint space all the way around the cuboid if the oblique is positioned properly. So that's all I'm going to say about that. So your ankle is basically a hinge joint, but it does allow for a little bit of abduction and adduction and rotation. And the ankle joint itself is formed by the tibia and the fibula and its articulation all the way around the talus. So it looks like that. So you've got the top portion of the talus. This is what we refer to as the mortise joint all the way around. This is not an AP of the ankle. This is an AP internal oblique of 15 to 20 degrees to demonstrate that mortise joint. So in a straight AP of the ankle, what we're going to see is some superimposition between the tibia and the fibula. Also, when we get to the knee, you'll see that in a straight AP, there's some superimposition on the tibia over the top of the fibula there as well. So the mortise joint is what we have here. This is the top of the talus. We've got the tibia, and we have the fibula on the lateral side. We also have sesamoid bones under the first, that's again the great toe, under the first metatarsal phalangeal joint, or really under the head of the first metatarsal. So we'll take a look at that. Back up on these, you can see, let me magnify this image a little bit. I'll move it over and magnify it some so that you can see where the drawings are. So those dotted lines right there really are supposed to represent the sesamoid bones. And the sesamoid bones are just there. Again, we have sesamoid bones where we've got a joint that bends very acutely. So those sesamoid bones are there because of the bending of the great toe. If we have a fracture of one of those sesamoid bones, that's what we refer to as turf toe. And some of you may know who Deion Sanders is. He was out for almost a full season. He played for the Dallas Cowboys. He was out for almost a full season because of one of those bones was broken. He had turf toe. Very painful, very hard to walk and run. Certainly hard to run. Any kind of high impact would make that significantly worse. So that's where your sesamoid bones are, and that's what turf toe is. I refer to that also in that other recording as well. So I'm going to skip from here down to slide number 92, and that is where our next anatomy portion picks up. Actually, that's where the fractures set in. So we talked about some of these fractures in the lecture, and you can see that in that first positioning video. So a Jones fracture is a fracture of the fifth metatarsal. It's the base of that fifth metatarsal. You break that tubercle off. And sometimes that occurs with foot injuries, but sometimes, in my experience, I've seen it probably more commonly all by itself being a fracture of the foot with ankle injuries. So sometimes you'll see that because of the ankle injury. And sometimes it may take a separate x-ray in order to visualize that, but sometimes you can actually see it on the ankle injury. So with the Jones fracture, you've got different levels of it. This is not testable. You're not going to see this on the registry. This is just FYI. So you got Jones fracture in different places. If it's very far proximal, it's going to be an avulsion, considered an avulsion fracture, but your Jones fracture proper looks more like that. And then stress fractures happen as well. So what this is an accessory sesamoid bone. I've not seen as many in the foot as what I've seen right behind the ankle. And I forget what os they call that behind the ankle, but it seems like it's an os tricatrum or something like that. I don't remember right offhand, and it's not important for you to know. It's just, again, FYI. So common fracture, the small toe. I think I mentioned in the video before that I've heard that referred to as a midnight fracture because you get up and you kick a door frame on the way to the bathroom and you break your little toe. I've not found any literature that would support that that's actually called a midnight fracture, but I thought it was kind of cool. And I thought it was a good name for it. This is a broken sesamoid bone. You can see a portion of the bone here. You can see a portion of the bone there, and it kind of gets dark in between. So that would be what we refer to as turf toe. Here we've got fractured tarsal bone, and I don't know exactly what the mechanism or what the presentation is. I know what the mechanism is, but I don't know exactly what the presentation is for aviator's fracture, but I do know that it involves fracture of the talus. And what I want to say is that the tibia potentially can go through the talus at least part way and fracture it. The one case that I had that the doctor was calling an aviator's fracture initially, I don't think truly was. What we had in that case, and it was plane wreck, plane crash, is that the patient braced themselves, and what happened is at impact they've got some abduction of the feet, so the ankles actually bent outward like that, and the tibia went straight into the floorboard of the airplane. And it was a nasty fracture, but the patient was going to be okay, probably going to walk with a limp for the rest of his life, but in as much as it being a life-threatening injury, it was not. So bone spurs I talked about, and that's what we're seeing here. This looks like there may be something more going on there. I don't know if the bone spur is broken off, but that's where the Achilles inserts into the heel. So I did mention in that if you have a calcaneal fracture, it's going to be very, very difficult for the patient to pull their foot back because as the toes back. Whenever we make a image, the axial image of the calcaneus, we need the patient to pull their foot back to a 90-degree angle. Well, the problem is that as we do that, the Achilles is going to be pulling on this, and it's going to have a tendency to want to try to separate the fracture lines, and it's going to cause the patient a lot of pain. So, for context, and let me make sure you can see that. That's the spur, and that's the insertion at the Achilles. So for context, this is what a calcaneal fracture could potentially look like. Both of these, this one's severe. This one, minimal displacement, but still, if you can imagine that the Achilles is going to be pulling on, you can see fracture lines going through. The Achilles is going to be pulling on that, causing those to try to separate a little bit. This is pretty much crushed. I mean, in both cases, what we've got is a comminuted fracture. You can see fracture lines through here, through here, through here, all the way up to there. So it's comminuted fracture. Remember, a comminuted fracture is a fracture that has three separate portions to it. So they're both comminuted fractures. This one is just mush. This is like a handful of gravel as a heel. It's just not going to be good. Ankle fractures, again, we can have a single malleolus broken, so the medial malleolus is broken and is held into place with what we refer to as a cancellous screw. The cancellous screw, if we were to magnify this up and move it, if we were to magnify this up, we might be able to get a better look at it. The resolution's not good enough. They look kind of like a wood screw, as opposed to these cortical screws look more like a machine screw. So if you're not familiar with what a wood screw is, you're very familiar with them. You've seen them. They're very sharp and pointy on the end, and they've got real broad, wide threads on them. So they're far apart. They stick up pretty far. And a machine screw, on the other hand, is kind of like what you see, what you if you were to unscrew the covering of a light socket just a little bit, look at the screw on that. The threads are very thin, they're close together, and the end of the screw is flat. So what they do with a cortical screw is they drill a hole and then they use a tap to actually put threads in the bone and then they put the screws in. So when you go to surgery, you'll see both of those. If you happen to see an ankle fracture replacement, you'll see both of those types of screws, most likely. I described in the lecture yesterday a syndesmosis. Apparently, this fracture did not disrupt the syndesmosis, so they don't have a screw going all the way across from fibula to tibia. But if they did, this hole right here would have a screw that goes all the way across and exits over on this side, or at least comes to the edge of the cortex of the tibia. I don't know that this is the same patient. It kind of doesn't look like it because I don't see the same uh, involvement with the tibia. It just shows the fracture unfixed. And then I did refer to a Massenet fracture, and a Massenet fracture is it's a ugly fracture of the ankle. And the ones I've seen did not have any broken bone involvement in the ankle itself. So this one has a posterior malleolus off of the tibia. The ones I've seen just had the proximal fibular involvement. So that syndesmosis, which I described yesterday as being kind of like a compression sock or tissue that just goes all the way up in between the tibia and the fibula, just to kind of hold it together real tightly so that you don't get a whole lot of movement of those individual bones. It just holds them in place, and that's what the syndesmosis is. And the syndesmosis is lost proximal and distally, so that what you get with a Massenet fracture is an extremely unstable ankle. So if you're in the ER and you get an order for an ankle and you go and you lift the ankle to put it on the image receptor and you have that ankle visually, audibly, and tactilely dislocate immediately as soon as you pick up the patient's ankle, I would bet that you've got a Massenet fracture. So it'd probably be a good idea to go and ask the ER doctor if you can just shoot a APN lateral at tib fib, because chances are that's what you got. You may have to shoot an ankle as well, but you may have to shoot an entire tib fib to catch it. So fixes for your tibial fractures, depending on the stability, probably the age of the patient, syndesmosis, and everything else, are going to vary. Okay, so I'm going to magnify this one up and I'll show you the other one and describe it here in a minute. So you've got a lot of different things going on in this picture. So in this particular x-ray, what you see is repaired um, fibular fractures. So you got a callus here, you got a callus here. But in this particular x-ray, what you're seeing is plates, or a plate with some screws going across it. Anytime that we have hardware, be it plates, screws, or maybe even a rod like what we're seeing over here, any kind of implant, anytime we're doing extremity work, what we need to see is we need to see proximal and distal to that we need to see both ends of that, be it a prosthesis or a plate. The reason for that is that if this patient, if let's say this is a follow-up exam, or worse still, this patient was in an accident after having this repair done, the most likely place that that tib fib is now going to break is right above, excuse me, right above that plate. You've got something hard holding everything together. It may be titanium and stainless steel, maybe an alloy. But if it's rigid like that and you get some sort of additional trauma, it's most likely to fracture right there. So if you get a order for an ankle and you just include what we normally include on the ankle, you're going to miss what a fracture is. So you have to include the entire prosthesis. Also, though, depending on where the fracture is, if we really need some stability, then what they can do is what we refer to as an intramedullary rod. So what they do with that is they poke a hole in the proximal portion of the tibia and they hollow out the medullary cavity. They'll put this long flexible rod in, and then they'll go over the top of the rod with a kind of like an auger bit, and they'll hollow out all that trabecular bone that's inside, and then they'll hammer this thing, and I say hammer, I do mean hammer. They'll hammer this rod all the way down into the patient's ankle, and then they'll put some locking screws, proximal and distal, so that things can't move around. Very, very stable once they get this thing into place. So now we're going to talk about the anatomy of the tib fib, and it doesn't take all that long. So by anatomical definition, what we're talking about when we're talking about tib fib is the leg. The leg is not the femur. If we're talking about the upper portion of the leg, we're talking about the femur. So the leg itself, leg refers to the lower leg, which is tib fib. So in the tibia is big bone on the medial side, fibula is the small bone on the lateral side, and you got a lot of features. I mentioned before that you have some superimposition on proximal and distal end. We'll talk about how we can eliminate that. Uh, I've already talked about it in the other video, in the first positioning video on the ankle. 45-degree internal oblique desuperimposes the tibia from the fibula so that you can see the distal portion of the fibula without superimposition over the tibia. Also, internal oblique on the knee is going to give us the same thing on proximal end. So smaller anatomy that you need to be aware of. It is testable all the way through the registry, things that you need to know. So articular surfaces, remember, um, uh, are referred to as condyles. So we've got a condyle here, we've got a condyle there. And it's kind of like a flat top mountain you may see in Western movies. Certainly we see it in mesas out in West Texas and New Mexico and the desert Southwest is flat top mountains. And we refer to those as plateaus. So the top of the tibia being flat like that, we refer to that as tibial plateau. But it does have this thing in it, and that's what we refer to as an intercondylar eminence. So the ligaments and tendons that go through the knee certainly pass through here and attach. I'm not going to cover those because we're not going to test on it. I don't know that there are any test questions. I know there's none on my test. And I don't know that I see any in registry review books either referring to those ligaments and tendons. So it would lead me to believe that they're probably not on the registry. So just kind of the same thing here, but we do have another tibial tuberosity that's sticking out front. So a common childhood uh, malady is to have injury to that tibial tuberosity. That's where it kind of pulls away from the tibia itself. So you may see that occasionally as well. So on distal end, what we have is medial and lateral malleolus. And again, you may hear that referred to as malleolus, and that's fine. But those are those knots that you can feel on either side of your ankle. And then the area or the joint space that goes all the way around the talus is what we refer to as the mortise joint. It is a long bone. I did not the both of them are long bone. I did I forgot what I was going to say. Did not something. Uh, I did mention in the video yesterday that in the lecture yesterday that in my experience anyway, the more common compound fractures are going to be the tib fib, just because the anterior portion of the tibia, the skin on the anterior portion of the tibia is thinner than most of your other extremities. And so since it's a long bone, both of them are long bones, but since they're long bones, they have a tendency to fracture and become sharp. So sometimes we'll poke through the skin. I really recommend, I mentioned it on feet yesterday, but I really recommend that you also put your gloves on whenever a patient comes in. They're on a backboard, they're in a trauma. Um, you, you kind of need to put your gloves on before reaching under the patient to pick the patient up for a couple of different reasons. One is there may be glass under, excuse me, under the patient. And those gloves aren't going to do a whole lot to stop the glass, but possibly they might help a little bit. Um, and the other is because if the patient has a cut or compound fracture that went out of the back, then you potentially might not know that until you get your hands under the patient and pick them up. So you want to protect yourself. The worst needle stick or sharp stick I ever took, it was in a trauma situation and it had nothing to do with the needle. The patient was an IV drug user, and a lot of people got exposed that day. But in the hospital where I was working, in order to do a trauma, we had to pick up the backboard quite a bit. So putting my hands under that backboard, there was blood under the backboard, and there was also broken glass under the backboard. Cut through my glove, cut through my skin, and I got exposed. Fortunately, the patient was, uh, even though he's an IV drug user, he had no uh, related illnesses, so everything was fine. But that potentially could have been bad. So in a trauma situation, take care of yourself first. I know some of your hospital protocols ask you to not wear gloves because wearing gloves might give the patient some sort of feeling like isolation, and it's more of a personal touch if they feel skin. Take care of yourself first. All right, so the fibula does not bear weight, and what you might see sometimes, let's just instead of magnifying that one up, what you might see sometimes is that if a patient is having a spinal fusion, where they might harvest the bone might be from the fibula. So they have a lot of different places that they can harvest bone. They can harvest from the fibula. Doesn't bear weight, just provides support, especially in the ankle. Um, they may use the iliac crest or they may use some donor bone. So you might see a situation where if a patient has a fracture, mid-shaft fracture of the fibula, they might not repair it at all. If it's stable, non-displaced, and it looks like it's going to heal itself okay, and the syndesmosis is still fine, then they may not repair it. Now the tibia bears all the weight, so if it's broken, it's going to need some some work. All right, so then we get to the knee, and in the knee we've got, of course, distal portion of the femur, and we've got condyles there that articulate with condyles on the tibial plateau, and that's what forms our femoral tibial joint space. But we've also got a patella, which is your kneecap. And we'll talk about that here in a second. For the most part, it's going to be a hinge joint. The patella is the largest sesamoid bone in the body, and we'll again take a look at it here in a minute. So just a look at what the ligaments and tendons look like. There are no questions on my test about those ligaments and tendons, so that's just for your information. So patella is the largest sesamoid bone in the body, and the base is at the top, the apex is at the bottom, and that seems a little bit backwards because you think of the apex of everything, including the lungs, or the apex of a mountain being at the top. But in the patella, it's upside down. So the apex is important to know where it is, because when we position for a knee, we're going to position our central ray just distal to the apex of the patella. So it's actually going to be below the patella to go through the joint space itself. So we'll talk about that when we get into positioning of the knee. So now we're going to talk about the femur. And the femur has a lot of features we need to talk about. It is a long bone. It's the longest, strongest, most dense bone in the body. And if it fractures, it can cause a lot of damage. We've got some major arteries that travel parallel to it. Common fractures are probably, most common fractures are going to be in your elderly patients on the proximal end. And we'll talk about that in positioning next week. So what we have then in the patella, or in the femur, is we have a head. This is the ball portion of the ball and socket joint. We have a neck. We have a greater trochanter. Remember, if we have something called the greater, we're probably going to have something called a lesser, and that's what that is right there. This is the intertrochanteric line. So where we have fractures is of the neck, and that's going to involve a surgical fix with 3 to 4 screws that I'll talk about next week. But possibly what we'll have is probably the more common of the two is what we refer to as an intertrochanteric hip fracture, and that's a fracture that runs pretty much parallel to the intertrochanteric line here. So what it involves is one great big screw that goes up into the head of the femur, and then a plate that runs down a portion of the proximal portion of the femur. So it's the largest bone in the body. The head is proximal, and the neck is just below that. Looking at it again, we got the greater trochanter, and it's very palpable. You can put your hand on your hip and kind of rotate your foot internally and externally, and you can feel that. The lesser trochanter is on the inside, and it is mostly obscured. So when we position, I'll talk about this next week in positioning class as well. What we want to do is get the neck of the femur as parallel to the image receptor as possible. There's a word that you need to file away. That word you're never going to see anywhere except for in reference to the neck of the femur. That word is anteversion. Anteversion. So sometimes your test questions will refer to foreshortening of the femoral neck, and the anteversion causes the foreshortening of the femoral neck. So if the patient's laying down, you think of yourself laying down flat on your back, your feet are probably pointing out like that. And what that's going to do is going to take the neck of the femur and it's going to rotate it so that you can't see the neck of the femur very well. So what we need to do is not just have the toes pointing straight up, but we need to internally rotate the toes just a little bit. And the way that test question is going to come at you is that we internally rotate the toes on the AP of the femur or the AP of the hip to overcome the anteversion of the femoral neck, and that's referring to as the external rotation, foreshortening the femoral neck. Excuse me, femoral neck anteversion. Just file that away. It's the only place you're going to see it. So those are the features of the proximal end. On the distal end, we've got epicondyles, and we talked about those before. Condyles are the articular surfaces where you get the articulation with the tibia. The epicondyles are on the side, and that's what you can actually feel. So what it looks like is this. You've got the condyles, the smooth articular surfaces, and the epicondyles are, again, those things that you can feel on either side. So I'm not going to ask you about your abductor tubercle or anything like that, but you do need to know about this place in between. Remembering a fossa is kind of a shallow indentation. The intercondylar fossa is the fossa in between the condyles. So that's this thing right here. And I think that is it. We'll talk about femur. I'm sorry. We'll talk about the pelvis, the anatomy of the pelvis before we start the pelvis section next week. But you can see why I kind of stress, really taking care to pick up the patient's leg, proximal and distal to a fracture, especially in the leg or the forearm, because those long bones can fracture and have very sharp edges, very sharp points, and you can actually do more damage to the patient. So I'm just going to scroll through and see if there's anything else I want to show you. Go. All right. So some of the fractures, we kind of talked about these already, plates and screws. I've never seen a plate this long on the tibia. It's extremely long. Most of the time they're very short, but this is what we refer to as an external fixator. External fixation is where uh, there's not enough stability in the bone to put plates and screws on them. So we have to give the patient basically an exoskeleton, kind of like a bug. And that's what this is. So what they'll do is they'll run some pins through the patient's what's left of their bones and try to align the fragments up the best they can, run the plates and screws through it, and this then becomes the supporting structure of the bone. And they'll leave these in place until the bone heals well enough that they can remove those and the bone becomes the stability again. So external fixation, you may have seen this. It's pretty rare, but you may have seen somebody walking around and they've got this thing on their head. So it goes partway around their head and it goes down to their shoulders. And on the shoulders, you've got these rods that provide support for this thing on their head. And that's the type of external fixator that we refer to as a halo. So the patient has a broken neck of some sort, and that provides the stability in that case. So just like a hip nail, I described what a hip nail looked like earlier. And that's with a big screw that goes up into the patient's hip and a plate that goes down beside. This is kind of the same thing for a tibia. They can do the same thing for the distal portion of the femur as well, but this is kind of like what a hip nail would be to a tibia. So you've got a plate here with screws going all the way across. The patient probably has at least a couple of fracture lines running through the tibial plateau. Broken patella. That usually involves a couple of pins and then a wire that kind of wraps around it to hold the whole thing together. So this was a knee replacement. This patient looks like they're pretty osteoporotic. So this was a knee replacement, and then we have a fracture just proximal to where the hardware was. So this femoral fracture is too low for a hip nail, so they put an intramedullary rod into this patient. So you got a screw that goes up into the hip, and then this rod is actually going through the femur. This is not a hip nail. This is an intramedullary rod. So if you're ever doing a surgery rotation and they have some sort of IM rod, really recommend you get in on it and see it. But it's not for the faint of heart because it's going to take a lot of hammering and a lot of drilling to get this. And they're usually pretty bloody. So I hope you have lunch before you go in for an IM rod, but they're well worth seeing at least once just to see how it is that some of these bones have to be fixed. So I hope this was helpful. Again, I'll finish up the lecture on the anatomy of the pelvis next week. Probably throw in just a little bit more in a separate recording to bring us up to maybe the distal portion of the femur sometime this week. Thank you for watching.